Dear colleagues, welcome to EHJ Today. I'm Filippo, Crea, Associate Editor of the European Heart Journal. I am in London for the annual meeting of the European Society of Cardiology, and I'm sitting with Dr. Townsend from Oxford University and Dr. Knapton from British Heart Foundation. As you probably know, Dr. Townsend is an eminent epidemiologist and has just published a very interesting update on epidemiology in Europe in the European Heart Journal. Can you tell more about this very interesting recent data?
Yeah, thank you. So this is a paper that we published every year for the last 2 years in the European Heart Journal. And effectively what it does is updating the epidemiology of cardiovascular disease and the burden of cardiovascular disease within Europe. And this year's figures make very interesting reading. What we find was very encouraging within mortality is actually decreases across Europe really from deaths and death rates from cardiovascular disease. What is more worrying is actually we still see inequalities between countries across Europe in death rates and in treatment and morbidity as well. And also inequalities between sexes, between the genders, with death rates higher within men than within women. When we look at the absolute burden actually of cardiovascular disease and death rates, we actually find a greater number of women dying within Europe from cardiovascular disease than men.
Any comment, Dr. Knapton?
I thought these were interesting from a number of points of view. The first is the magnitude of the burden of cardiovascular disease in Europe. So we've all heard about the trends that are improving, but just short of half of people in Europe are dying from cardiovascular disease still, much more than almost double the rates from cancer. And there's certainly in Britain, from a British point of view, there's a sort of sense that things have improved so much that cardiovascular disease is a problem that's been solved, and it clearly has not. And then the second, as Nick says, is the inequalities, not only between countries, but within countries. So whilst the UK might be doing better than others, and particularly it's the Mediterranean countries that seem to be doing best, within those countries there will be still pockets of deprivation with associated burden of cardiovascular disease.
How do you explain these inequalities? Reduced access to prevention, treatment, genetics, or what?
I think it's the combination of the two, really. When we look at certainly decreasing trends in countries where we have, you generally find a decrease, split about 50-50, largely through a decrease in incidence and also through better treatment, so better treatment to those people who are actually getting cardiovascular diseases. And really what we find, we look at these inequalities across countries, we find both within these behavioural risk factors but also within access to health care. Now, within the paper we discuss mortality rates, but we also discuss prescriptions and treatment from surgical interventions. And when we look at maybe the enormous burden within Eastern Europe, we can point to certainly the high smoking and alcohol intake rates of particularly men in Eastern Europe and not such great access to health services. So this really inequality comes down to these two factors, both within the prevention from behavioural risk factors, but also in the treatment of people who are actually suffering from cardiovascular disease.
If I've well understood, there is a negative message for women. Do you know why? Well,
really, actually, the data is quite interesting because when we look at an absolute number of deaths, yes, it is greater within women than in men. And also when we look at a proportion of deaths as a sheer percentage, again, it's greater within women than within men.
This is age corrected.
This is before we age correct it. Once we age correct it, then actually the death rates are greater in men. What's interesting from the woman point of view is the focus that you get for certain conditions such as breast cancer and other cancers. When we look at coronary heart disease versus breast cancer within Europe, it's about 2% of deaths within women in Europe come from breast cancer and about 20% come from coronary heart disease. Much larger than I think a lot of people would think. It is a greater burden within men, though. When we take into account and we age standardise it to the new European standard population, actually the rates are higher in men than women. It just simply happens because of the increased longevity of women, because of the larger population of women in Europe, we have a greater number of deaths within Europe from cardiovascular disease within women.
So the bottom line is that women are not more susceptible, but equally susceptible to cardiovascular disease.
Certainly not more susceptible. And when we look at premature mortality under 65 and under 75, that reverse changes. What we have is a greater number of men under 65 dying from cardiovascular disease than from women. So there's still a greater susceptibility amongst men. I think what is interesting is actually from an absolute burden, it's very high amongst women. And really, you've had this idea that cardiovascular disease is a male disease. And actually we need to stop looking at it that way. It is shared amongst the population, and the absolute burden of cardiovascular deaths amongst Europe is very high amongst women.
And by the way, at least for early infarction, less than 55 or 60, mortality is higher for women than for men. Did you explore this aspect in your epidemiological study?
We didn't. We looked at coronary heart disease specifically, and within that we found certainly the higher number of deaths amongst men than women. What we didn't then look at is obviously in later specific conditions such as infarction. I think the other issue that we have obviously is again with these inequalities that we have. We know that maybe between women and men there's some protective factor when it comes to hormones, so estrogen for example, which equals out post-menopause. But we also again have inequalities and differences between men and women in the behavioural risk factors. So in a sense some of the inequality we accept because it comes down to biology, some of it we shouldn't because it comes down to behavioural risk factors.
Comments on these important issues?
So I think it's very important to remind ourselves that this is a disease that affects men and women, shall we say, equally. I mean, there may be differences, but on the whole, it's a burden on both genders. And I think the perception remains in both the lay population and to some extent the professional populations too, that it's a disease that affects men, and we see this flowing through in terms of outcomes from treatment for cardiovascular disease. Women tend to present later, they tend to present with more atypical symptoms, and I think part of it is to do with the awareness that people have. And women themselves, in research that the British Heart Foundation have done, attitudinal studies, tend to put their symptoms down to something other than cardiovascular disease because they don't believe they're going to get it. And that means that they can often miss symptoms and therefore present later and therefore do less well from the treatments that we can offer.
Well, and this is a very important message for our women in Europe. But not only in Europe, what about a global perspective? How do you see your data in the context of?
Well, interestingly, still cardiovascular disease is the biggest killer within the world. And actually what we found really within Western Europe and the more affluent countries, these steep decreases in cardiovascular disease mortality with improved treatment and intervention. But actually in the rest of the world, particularly in these less affluent countries, it's going to be a greater and an increasing problem. And so really the burden of cardiovascular disease, along with other non-communicable disease, is only going to grow really globally. And I think even just looking at the UK and looking in the Western countries, and within Western Europe, we've seen increases in diabetes, we've seen increases in obesity. These death rates and decreases in improving outcomes that we're celebrating at the moment, they might not stay with us unless we do something to counter these medical risk factors which are increasing as well in the population. And that stands within the UK, within Europe, and within the world as well.
Funding is an important issue. Are you satisfied with the funding of your study? Do we have support from the British Heart Foundation?
Yeah, so I run a cardiovascular disease epidemiology program that's funded by the British Heart Foundation. They've been very supportive to us and our group over a number of years. And actually the British Heart Foundation is the biggest supporter of cardiovascular disease research, certainly within the UK, potentially within Europe itself. What we would like to see, of course, we want to see more money come in, but we'd like to see it go towards the prevention side as well. It's not just about treatment, it's not just about clinical intervention, it's also about stopping people get to a point where they do have to receive some kind of clinical intervention. The BHF is a big supporter of the work that we do, and we're very grateful, of course, for that. We would encourage that within other countries and across Europe. As well as inequalities in the outcomes that we find, we also find inequalities in the data collected and published. And that comes down to a funding issue and to focus within those countries. And we would say that if you can't get proper surveillance data within countries, you don't know what you're aiming at. You have a hidden target, and for us to actually make an impact on cardiovascular disease where you don't know what the burden is within a country is incredibly difficult, and then we'd also like to see some money go towards that.
Now, what about your suggestions based on this data for the clinicians like myself?
Well, we actually, I have to admit, look at population interventions. So we look at things that the policymakers and that countries can do themselves, governments can do. And really what we've seen with a lot of European countries, really good interventions to decrease smoking rates, particularly within Western countries where we've had higher taxation, we've had lots of legislation come in. And what we would like to do is let's build on these within smoking, but also use those kind of approaches amongst the other risk factors. So let's apply these things and consider some of these interventions, such as taxation, on things like unhealthy foods. And let's look at environmental change so that we can improve physical activity. To the clinicians, I think it's the same thing. It's about saying to clinicians, alongside the medical treatments, alongside statins and the drugs that you can give and are obviously very, very effective, let's look at the individual before they get there, and let's look at their behavioural change and their behaviour patterns so that we can actually change those so that in the future potentially they don't need that intervention, or if they do need that intervention, it is later in life.
Well, thank you for this very interesting conversation and for your participation to EHJ today. Thank you.